So thank you very much for inviting me to your seminar. It's a great privilege for me to be presenting at the Botner Research Center. As this is a children's theme, I'm a pediatric surgeon in Oxford and also do a lot of global work and research at the university. So I'm going to speak from the other aspect from the previous two speakers where you discussed high-end research, and I'm trying to put together as to what happens in low and middle income countries where research challenges are huge, not forgetting the clinical challenges. So as surgeons, we are very busy in the operating theater, but we are also thinkers and wanting to know how can we make things better for our patients. But the challenges are huge and even larger in low and middle income countries because the clinical service is extremely busy. Our specialty is skill-based, so we have to keep our skills sharpened all the time. There's no protected time for research, there's no funding, and there's no time. And in the Western world, where there are training posts created for surgeon scientists, where time is allocated for research for surgical trainees, they are suffering for lack of maintaining their skills because the time spent on clinical training is being cut down by research. So as a surgeon, how do you equip yourself for this role, and more so in the low-income countries? And I always say to my trainees and my colleagues in the low-income countries that you need to have an interest in research. And research can be a case report, case series, audits, systematic reviews, wet lab, dry lab. I mean, we got an example of both wet lab and dry lab from the previous two speakers. You can be involved in local research, regional research, national or international studies, or do degrees. But what is more telling is that in pediatric surgery, the training involves a fellowship where you train as a surgeon and then you get awarded a degree by a society or a college, whereas the university training will require a research project. So with my development of children's surgical research at Wits University in South Africa, in Johannesburg, I said to my colleagues that why don't you develop an MEd program? Because the MEd program forces all our trainees to do a research project. And in that way, this entices them, and there will be those that will continue to do it, and there will be those that will stop at the MEd project and continue their clinical work. And I also say to them that whatever you do and whatever you talk about, if it's not written, it never happens. And this is very much an American dictum. And you find that the Americans are very good at publishing very little things that we would regard as ordinary, because this is what they believe in, that if you don't write it, it never happened. So we need to catch up with them and also be as successful as them. So in developing, my experience of developing research in low-income country is my experience with my partnership with Tanzania in pediatric surgery over 22 years. So 22 years ago, there were two surgeons that were doing some children's surgery, but died within a month of each other. They didn't succession plan. And in that era, nobody succession planned because the skill was based on the ego of the surgeon. And Tanzania was left with no pediatric surgeons. So over 22 years, we capacity built and developed clinical skills and trained 15 pediatric surgeons to date, but also included research and simple clinical research projects so that the training and the interest is dual, clinical and research. And I remember that the first case report that we put together, it took me 14 revisions to get it right in a publishable form, but that was just determination to make sure that the work is done locally and the training is developed locally rather than being just done elsewhere, so that there's no skill development in the local country. So through that phase, we had 84 international presentations and published abstracts, and we have now 25 publications recently with what we have inputted into research in the past 3 years. So with a busy clinical service, it just so happened that one day while I was there in Tanzania, there was a trainee who came in and was taking details down from the theater logbook, looking at how many children were being operated on. And I kind of asked him, what were you doing and where did he come from? And this was a public health trainee who was collecting data for the hospital regarding children's surgery. And I enticed him to say, why don't you work with our clinical colleagues who are really busy but have lots of ideas? And if you could find a colleague, develop the research part of the pediatric surgery that we've developed, we would have a very successful research center. So I raised a bit of money and used my own money, and we formed a Muhimbili Oxford Training and Research Center, led by 2 local researchers from the public health training point of view, working together with pediatric surgeons and their training to develop research and relevant research in the department. So currently we started, and this happened in 2017, where we got a little bit of money to start supporting research workers. So the Greenwood family is a legacy family where Mr. Greenwood decided that his money should be spent on developing skills and research in low-income countries. So we started a project on a randomized controlled trial on surgical site infection, because the biggest problem that my colleagues were facing is surgical site infections in the children that they were operating on. So we got £25,000 from the Greenwood family, and I added a bit to that, and we employed 2 of those public health workers to start a randomized controlled trial on surgical site infection. And we did a very simple study where we randomized the children to receive whatever they do before surgery, and one group, the other arm, were patients that were being bathed with ordinary soap that you bought from the shops that didn't have any antiseptic properties. And the mothers were taught how to wash the children sort of behind the ears and around the nasal bridges and things before their surgery. The second project we did was looking at access to safe surgery. And the third one was developing a WHO checklist that was more appropriate to the country. So in the soap study, just by using simple ordinary soap that cost 2p, or in euro cents, about 3 cents, where we trained parents to wash the children in a certain way, we reduced the surgical site infection rate by 80%. And the cost of this was basically 3p for a piece of soap and £25,000 to provide salaries for the 2 researchers. And we have excellent results, which we're going to present next week in our International Pediatric Surgery Conference. And this work is already accepted by the BMJ, but we've placed an embargo on the paper until we present the work next week. In terms of access to safe surgery, as you heard about safety in children's care and safety of children trying to reach care, we looked at all the patients that arrived at this tertiary hospital as to their journey. How did they get there? How much did it cost for them to be there? And we found that as WHO has put in the figures that each person who requires healthcare should not take more than 2 hours to reach a healthcare facility for the problem that they have. And we found that most of the patients that arrived at the hospital were from the coastal areas. They were not reaching within 2 hours of the health facility for their need. Once they arrived at the major hospital, the government did provide health insurance, but it was only health insurance for the treatment, not for the journey of the patient to get there. So most of the patients were driven into poverty because they were out of pocket of about $70 for providing for each treatment that the children needed. We published this in the World Journal of Surgery, and just 3 weeks ago, I was in Tanzania, where we made a special trip to the Ministry of Health by invitation and showed these figures. And the ministry has now committed and have put into place that as of 2023, all children will have a health insurance, not just when they come into the hospital, but for their entire journey and the subsistence required for the family who bring the child to the hospital. We also noted, and these were all questions raised by my colleagues in the hospital, to say that the WHO surgical checklist was just not appropriate for them. And what they would like is to record the entire journey of the patient from the time that they leave the ward, for the recordings and the recordings of all the vital signs in the ward, to the area where the porter collects the child, then gets to theatre where the anaesthetist takes the recordings, then the safety check, then the checks for the nursing staff for all the equipment, then the surgeon's recording, and then the recovery room recording, and the patient's journey back to the ward. So together with the porters, the nurses, the anaesthetists, the nurse assistants, the nurse anaesthetist, surgeons, ward nurses, we put together this booklet, and then we trialed it, and we found that there was a 93% acceptance from the entire team as to the best way of providing information in one booklet. So there's a charity called Kids OR who are putting up theatres for children's theatres all over Africa for their need. And they're very interested in developing this booklet to then roll it out into all parts of Africa. At the moment, the booklet is sitting at the government level, because when you have booklets or information that required throughout the country, it has to receive the rubber stamp of the government. And we actually got the rubber stamp 3 weeks ago when we were there in person. We're hoping to get this printed out officially through the Ministry of Health. We're also working on point of care ultrasound. So we know that since we formed this Muhimbili Oxford Training Research Center, lots of ideas from our local colleagues are coming into the center, and we are developing projects together with our local colleagues and whoever we can collaborate with. And on the POCUS, we are collaborating with a German group who have already developed POCUS, have done the training, they know how to teach it, and they are teaching it to physicians in Africa. And we've approached them, and together with a PhD student that I've acquired, we are going to be working on pediatric surgical trainees to be able to use POCUS so that they don't have to wait a day or 5 days to get an ultrasound scan from a radiologist. So most of the POCUS training is on very basic skills and not complexities. So in Oxford, my theme for research in the past 5 years is global children's non-communicable diseases. And there are 3 areas that I'm concentrating on because those are the most needy areas. The first one that we've already done is during COVID, there were lots of studies being conducted, but children, especially children with surgical needs, were definitely forgotten. So in Oxford, with my research team, which is just 2 other people, we conducted a multi-center international collaborative study, totally unfunded. Now, during COVID, almost all the medical schools were shut. And I kind of approached all my colleagues internationally. And within 2 weeks, I had about 100 countries wanting to sign up for the project, where we wanted to see what COVID-19 did to children with cancer. Our medical students around the world put in their efforts. They did infograms for us. They did this kind of pictures for us. They sorted out our REDCap collection database. They did posters, they did informations, and they also controlled the communication for us between all our colleagues around the world and us in Oxford. And within a short period of time, we had over 2,000 patients registered, with trainees, consultants, and junior doctors working together, where most of the work was done by our junior doctors, but the consultants actually looked at the quality of the work was correct. Our outcome study showed that in LMIC, it's a postcode lottery, that if you live in a high-income country, you are fine because all the resources are there. But if you're born in the low-income countries, you have a 40-fold chance of dying from your cancer at 30 days and at 90 days. And we had this data presented at an international cancer meeting by one of our LMIC colleagues who produced the most amount of data, and he won a prize for this presentation. The work is now been published in the BMJ. We also have completed our 12-month study, where it shows that death at 12 months, it's dependent on income group, ASA grade, or tumor type. And this work is accepted by the BMJ again, but we've put an embargo on the paper because we're presenting the work next week in an international pediatric surgery meeting. But we haven't stopped there. That now that we have this data, we have formed specific tumor groups, which is identified by the WHO, who felt that there are 10 tumors whose outcome by 2030 should be equivalent around the world. Because if you take a tumor like a Wilms tumor, which is a renal tumor affecting children, the death rate in low-income countries is, the survival rate is almost just 20 to 40%, depending whether you're in a low or middle income country. Whereas in the high income country, the survival from this tumor is almost 80% and above. So we have started forming protocols. We have developed surgical operative note templates, and we've approached multiple charities to provide certain type of chemotherapies that is sustainable and relevant for the countries that we've worked in. We're also doing it, I'm also supervising MEd student jointly in my previous alma mater, which is the University of Witwatersrand in Johannesburg. We're working together with my colleague, Dr. Harrison, who you see above. And then below that, you see Dr. Kruger, who is again a public health social scientist working with us to look at our experiences and compare our high-income country and middle-income country experiences, and where can we make the changes to improve cancer care. We have not forgotten nursing group. So in 2020, the nurses celebrated the International Year of Nurse and Midwife. And in that year, together with our Global Initiative for Children's Surgery group, we put together a nursing group who wanted to study healing of wounds of infants and children globally. So together they've put their questions together, they've put their study together, and we have just received international ethics approval. So the ethics was driven through India, and that was then accepted by most of the other countries who had looked at the protocol and provided ethical approval without much difficulty. The most difficult part was to get the first ethical approval, and we hope to start the study in the latter part of this year. Trauma is another killer. So worldwide, I mean, trauma kills more children than HIV, TB, and malnutrition all put together. And Zimbabwe is a country where trauma care has not got better, but deteriorated, unlike other countries where death in children from trauma has got a bit better. So together with the chief investigator in Zimbabwe, Dr. Mguti, Professor Mguti, who was the previous president of COSEXA. We've worked together with Professor Habib, who's a pediatric surgeon in Sao Paulo in Brazil. And she, for her PhD, worked just in her city by educating parents and children and teachers and reduce the death from trauma by 40%. So basically the death rate from trauma there, which is a lot of stabbings, gun shootings, and motor vehicle accidents, there were 6,000 deaths per year, and she reduced that to almost 3,500 deaths per year, just from simple education of families and teachers. I'm currently have just completed the protocol for birth defects. So we're going to be working together with our colleagues in Bangladesh. Dr. Rahman, who's on your left-hand side, is a social scientist. And on the right-hand side is Dr. Tahmina Banu, a very good colleague and friend of mine who's a pediatric surgeon. So the reason for taking up birth defects is in Bangladesh, my colleagues are really concerned that birth defects is a major stigma for the families who have children with birth defects. They either have to allow them to die by not caring for them because of the stigma, and it drives them into poverty. So we're going to be running a project together with the government who's supporting 50% of the work, and the other 50% is just voluntary, by training local healthcare workers, medical teams, doctors, junior doctors, into educating the population about about how birth defects can be treated and that they shouldn't be stigmatized. So it is a huge social scientific project, which we hope to run over 5 years. What we've also done is we find that most of children's surgery in low and middle income countries is done in the district general hospital in usually an unsafe way, not by willingly, but just because there's no other way. And there's a huge lack of anesthesia. And most of the children are anesthetized by nurse anesthesia, who are trained to look after adults and are forced to do children because children arrive at the doorstep. And if you don't do anything, they will die. So knowing that this is a problem, together with our colleagues in Vellore in India, we formed a training program where we are training teams of adult nurses, anesthetists, and surgeons, which are orthopedic surgeon and general surgeons, in doing simple children's surgical procedures or preparing the children for transfer of those that are complex, so that it is the safety factor is there for children who have surgical needs. So we ran 3 pilot studies in India where the pediatric surgical team from the tertiary hospital trained district general hospitals. And we found that in our outcome, 30% of referrals were reduced because they were not needed. 90% of appropriate referrals were received. 78% when they arrived to the tertiary center were well resuscitated. 20% of procedures were done remotely, such as advising a colleague, a surgeon out there, how to put a suprapubic catheter, which you can talk them through. And almost 80% of the radiology and pathology is now reported remotely. We have published our concept in one of the international global health journals, and we are now preparing to train teams from Africa, mainly Ghana, Tanzania, Zimbabwe, Ethiopia, and Kenya, who have come forward to want to run these projects in their own country. And we're running a training session in the 3rd week of February next year. Also coming to our trainees, so in Oxford, the junior doctors who are just post medical school training, will come out in their first year. Some of them want to become academics and are put into the pathway of surgeon scientists or a scientific training scheme. So what happens is that they either get a day off a week to do research, or they get 3 months off in a block to do research, or they get 12 weeks in a year. So they get 2 weeks every 2 months to do some research work. And these are some of the projects that I did with them. And most of them have come wanting to do some project in low-income countries where they grew up or where they had some family connections with. So we developed locally relevant clinical guidelines for procedure-related neonatal analgesic practice in Kenya. So Kian Wade was one of those junior doctors, and he came to me wanting to do some research in Kenya where he has family and has been there for his elective. And I said, look, it will be good to look at how much of children's surgery has been done in the local district hospitals. And we went back to our colleagues in Kenya who came back telling us that, no, we don't want that. We really want to know how we can work on neonatal analgesia and reorganize our practice, because we are using multitudes of drugs which are not working, and it is very expensive, and we don't think we are getting it right. So together with our Kenyan colleagues, we developed guidelines through our systematic review. And we found that in low procedures, like blood taking, breast milk and sugar is the best form of analgesia. And that paracetamol works extremely well when you're doing something like a lumbar puncture, which is like a middle analgesic requirement. And for major surgery, morphine is the best. And just by reorganizing the way we practice our analgesic guidelines in neonates, we reduce the cost of analgesic drugs for the government by 65%. And the Ministry of Health have endorsed these national guidelines for us. Similarly, another of the training who wants to be a hematologist wanted to know, any perioperative blood transfusion practices in low-income countries, because her family tree her family ancestry originates in Bangladesh. And also my colleague from Bangladesh, whose picture you saw earlier, Tahmina Banu, said that a lot of the times there's a lot of blood being wasted, and some patients are over-transfused or under-transfused. And in Bangladesh, if you do need blood for children, you have to go and buy it from the blood bank, or families come. So if a child needs an operation, the entire family will come from the rural area because the child might need blood, so that the family can be tested and bled for the child's or their siblings or their family's operation. And also there's an unwritten rule in the hospital that every doctor's blood group is tested. And if a child needs blood and there's no family member to provide it, the doctors or medical staff bleed themselves to provide blood for the families. So we did 3-phase studies. We've completed all 3. 2 have been published. The first one in the Lancet about what is the preoperative anemia threshold for children in low-income countries. And unlike in our settings, we found that most of the children are anemic, and they are very well, they manage very well with a hemoglobin of 6 or 7. So we used that as a threshold. And then we looked at the current practice, transfusion practice, and realized that there was quite a lot of wastage of blood, and that a lot of the clinical assessment of anemia was correct. And a lot of the time, a hemoglobin was not needed because that also costs money. So for the 3rd phase of the study, we bought hemoglobinometers for the team out there, which are easily just to take a pinprick and test the hemoglobin before surgical input. And we found that just by doing so, the impact of cost saving has been $3 million for Bangladesh for a single hospital. And our two studies, the phase 1 and 2, are in the Lancet and the World Journal of Surgery. And the third one is been accepted by the Lancet, but again, being presented next week. And we will not release that until the presentation is complete. Another thing regarding undergraduates. So in Oxford, which is quite a wealthy area, a large number of our students go for the elective in all over the world, especially to low-income countries. And they came to me asking me for advice as to where should they go. And I thought here was a great opportunity to get them to focus. And I said to them, called up all of those that were going for elective to say, why don't, when you go to a low-income country, why don't you partner with an LMIC student as your partner for your entire training program, but initially for the time that you're going there. And I will give you a theme project for all of you to take and study that particular condition in the LMIC countries that you are. So in a group of 30 students that are gone abroad, they will all study a project that I'd given them together with the LMIC partners. And this project the concept became very popular. And for the first 3 years, I gave them kind of an idea of what topics to do. And in the last 3 years, so this is running for almost 6 years, they are choosing their own themes from LMICs. And almost every project that they've done has been a prize winner, has been published. And just from the concept of using elective students and bonding with the students received a lot of attention in the research world. But what has also happened is this is not just the end of the project, in that these students have bonded with the LMIC partner lifelong. And that is the theme, that is the requirement. They need to do that. So they share their student experiences, they're sharing their junior doctor experiences. Some of them are already into training into specialty, so they're sharing their specialty outputs and education. And soon as consultants, they'll be sharing the experiences and doing joint projects. I'm going to now move on to advocacy. So in most LMICs, up to 50% or over of people in the country are children. And almost 2/3 of children worldwide do not have access to surgical care. 85% of children will require a surgical procedure before their 18th birthday, be it a tooth extraction. And surgery is not expensive, because this is a very common criticisms or a language spoken by our medical colleagues that, oh, surgery is very expensive and it shouldn't be invested in. But if I give you an example of an HIV treatment for life for a child who's 11 years old, it costs $300,000 US for that child to survive for the entire time of his life. Whereas an inguinal hernia repair would cost $50. And this person will bring in a lot of economic input into the country. So surgery is not expensive. So in 2016, the Lancet Commission placed surgery into the global health arena to say that malaria and HIV and TB and malnutrition are not just all global health problems. Surgery is also a global health problem. And they put out figures there that 5 billion people out of 7 billion do not have access to surgery. And if you don't invest in surgery, then there will be a $21 trillion loss to every country by not investing in surgical, in surgery on a global scale. But as you've heard from the first speaker, they forgot about children. Nobody talked about the need for children with surgical needs. So some of us got together and we formed an organization called the Global Initiative for Children's Surgery, very much aligned to UNICEF. But what we did is we embraced all children's surgical carers, because the Lancet Commission only talked to surgeons, whereas what we've done is we've got anesthetists, nurses, surgeons of all specialities, radiologists, advocates, administrators, anybody involved in children's surgery are part of this organization with a vision of safe, affordable, timely surgical care for all children. And from the beginning, we were very, very clear that our organization is going to be LMIC dominated. And the way we've done that in the organization, any HIC member who wants to join the organization needs to bring 2 LMIC partners into the organization. So it will always remain 2/3 LMIC, 1/3 HIC. The first thing we did when we formed the organization in 2016 is that we produced an optimal resource document, which is a standard setting document for children's surgery. So if you want to develop a children's anesthesia in your hospital, this document has the standards that you require in terms of equipment, in terms of human resources, in terms of structure of the building, in terms of research needs, in terms of the size of the hospital, and so forth. So anybody, even an administrator, or if you say a donor wishes to donate a children's hospital, this document will provide all the standards requirement for a children's hospital. We are waiting for WHO to approve this document, and it is available on, with that link. And we published all this data in the World Journal of Surgery. But it is a document that we have revised last year, so it's up to date currently. We also collaborate with a large number of organizations promoting the need for children's surgery because, as I said, children always get forgotten. You find companies will say it's too expensive to produce children's equipment. So yes, we have advised people, we have re-educated people, and one of our champions is Kids OR, who are building children's theaters in many hospitals so that we don't have to share with adults 2 days a week, or if a seizure comes about, then children's theater goes down. And my personal experience in Tanzania was that, we had a 3-year waiting list because we just didn't have access to theater. And with Kids OR putting up 2 theaters for us in Tanzania, the waiting list was reduced in 3 months. And now we just don't have a waiting list. Anytime a child needs an operation, we have a theater for them because one is an emergency theater and one is a children's theater for elective work. What we are struggling with is UNICEF. We've made lots and lots of approaches to UNICEF to work with us, or we would like to work with them because all of us are working with children, and whether they have surgical needs or medical needs, they are children in need. And we hope that in the next year or 2, we will break that barrier and be able to work together. So in conclusion, I'd like to say that it's important to work towards equity so that justice can be achieved, because the reality, as you see in the slide, is that we have over-resourced places, like a lot of us in high-income countries, and the child in the purple shirt has nothing and can't even see over the fence because the fence is the barrier. A lot of people feel that if you equally give resources, then we will win, but you don't, because some people's starting point is at a different level. However, if you have equitable distribution of resources, we will achieve justice in no time, as long as we practice equity in healthcare. Thank you very much for your attention, and I hope there might be time for some questions.